Thank you, Aris, for inviting me again. It is always a pleasure being your guest. Thank you for your hospitality. And I have been asked by you to try to answer what NIPT cannot do, but maybe a better question would be what NIPT cannot do yet. Because although the history of NIPT, as it is done nowadays, started more than 20 years ago with the publication of Dennis Law's paper on the presence of fetal DNA in maternal plasma and serum, NIPT was not, did not become commercially available until 2011. That is less than 10 years ago. That means it has still a long way to go, and I'm absolutely sure that there will be many improvements in the next few years. But before trying to answer what it cannot do, I would like to spend a few minutes explaining you how NIPT works. You all know that all people have cell-free DNA in their blood, but when a woman becomes pregnant, she has also fetal DNA, cell-free DNA in her blood coming from the apoptosis of cytotrophoblastic cells of the placenta. And these fragments of DNA could be then obtained and sequenced and compared against a reference with the NIPT test. And there are mainly two approaches to study this cell-free DNA. One is the single nucleotide polymorphism-based method. This method uses targeted sequencing. It only sequences specific areas of the genome, not the whole genome. And on the other side, there is only one test that uses this approach, that is the panorama test, commercialized by the Natera laboratory. And we have, on the other side, the counting approach to do NIPT, and this methodology could use also targeted sequencing as the SNP-based method, and there's only one test that uses this approach, probably the most known one, because this is the test that the group of Nicolaides used in all these studies, the Harmony test from the Ariosa laboratory, and then there are some that use MPSS, multiple parallel shotgun sequencing. They sequence the whole exome and then use this for the study. This last approach is somehow expensive, more expensive, because it has to sequence the whole exome. And using this approach, you find the verified test from Bernat laboratory and maternity 21 plus from the Sequenom laboratory. And how do these methods work? Counting methods are based on the fact that we already know from the Genome Project how many genes come from each chromosome, and therefore we can compare the amount coming from a given chromosome of interest, for example, chromosome 21 or 13 or 18 or X or Y, to a chromosome from which we know that it will always be euploid in the fetus, for example, chromosome 3. All pregnancies that arrive to 9 or 10 weeks of gestation have always a diploid content of chromosome 3. So when the sequencing is done, the chromosome fragments coming from chromosome 1 are identified, then that of chromosome 3, and then the amount of each chromosome are compared to each other, and if the ratio is the correct one, it is assumed that the fetus is normal, whereas if there is an excess of fragments coming from chromosome 21, but it's the same for 13, 18, whatsoever, then a trisomy is suspected. On the other hand, the single nucleotide polymorphism approach looks for sequence variations occurring when a single base pair is changed, and from the Genome Project we know exactly where all SNPs are located in the exome, and if these are changed, we have fingerprints of every person. Then when the SNP approach is used, not only the plasmatic mixture of maternal and fetal DNA is sequenced, but also the DNA coming from nucleated cells of the blood that are only of maternal origin, and then both genotypes are compared with bioinformatic algorithms, and the fetal genotype is then extracted. But let's go to answer the question what the test cannot do. And the first answer is that the test cannot give back a result in 100% of the cases. As any other laboratory test, it has test failures that we refer to as no calls in NIPT. And these test failures could be related to administrative causes. The sample is not properly labeled, or it is lost during transportation to the lab, whatsoever. It could be due to assay failures, DNA extraction does not succeed, the amplification does not work, the sequencing goes wrong, and so on. Then these two causes are really very seldom, unless the laboratory is a disaster, but usually they are not. So the most frequent cause of no calls is a low fetal fraction. And the amount of no calls may differ between the different approaches. As you can see in this slide, if you use whole genome sequencing, MPSS, the no-call rates are very low, around less than 1%. In case of Verify that you told me that you use in France, it is just one in 1,000. On the contrary, you can see that in tests using targeted sequencing, this no-call rate is much higher, even rising to 6.4% in case of panorama test, although in our hospital we do use the panorama test, and our experience is different. After having performed more than 1,600 panorama tests, in our hospital we only had a primary 1.5 no-call rate, and after second draw this no-call rate dropped to 1 to 4 in 1,000, less than 0.4 per 100. And how did we achieve these low numbers? First, we always do an ultrasound at 8 weeks of gestation, where we can discard vanishing twins and also properly date the pregnancy, thus avoiding to perform a non-invasive testing too early. And in second place, we also don't have many obese patients, and as we will see later on, there is a higher incidence of low fetal fraction in patients that are obese. So fetal fraction is usually quite low at very early gestational ages, and this increases with gestational age. Therefore, although the laboratories tell us that we can start doing NIPT as early as 9 or 10 weeks of gestation, I would recommend you to perform the NIPT starting at 12 or 13 weeks of gestation to avoid low fetal fractions. Also, as I told you, maternal weight has an impact on fetal fraction, not only because the fetal fraction is lower, but because in obese patients there is a higher amount of cell-free DNA coming from the own mother. So if a patient is very obese, it is probably not a good idea to perform NIPT. And this is a slide that tries to illustrate how the fetal fraction affects the sensitivity of the test, not only the no-call rate. As you can see in the right of the slide, if the fetal fraction is high, the difference between an euploid and trisomic pregnancy is much higher. And the difference becomes very narrow if the fetal fraction is very low. And that explains also that there is a higher incidence of false negatives if the fetal fraction is low, especially in NIPTs that use counting methods. Nowadays, no test gives us a result back if the fetal fraction is lower than 4%, although this will probably change in the next future as the technology is improved. I think then that in the next future they will release results with lower fetal fractions, but nowadays it is 4%. Between 4 and 8% of fetal fraction, these are considered intermediate fraction, and the test that uses SNP approach works pretty well with these fractions, but if you use accounting methods, the sensitivity may be reduced. So if you have an abnormal ultrasound and the NIPT using accounting method tells you it is normal, but you have an increased nuchal translucency whatsoever, don't rely on the result of NIPT. And finally, if the fetal fraction is above 8%, then the fetal fraction is adequate to achieve best performance with all the tests. And besides low fetal fraction, there are also other pregnancy-related causes for no calls. If you usually use the test, the panorama test with the SNP approach, you cannot use it if the pregnancy had been achieved by oocyte or embryo donation, or it is a surrogate pregnancy. Do you have surrogate pregnancies here? Okay, if it is a surrogate pregnancy, you can also not use the panorama test, because besides the maternal and the fetal DNA, there is the DNA content from the biological mother that could not be integrated in the algorithm yet. Maybe in few months or years it is possible. Also, if there is consanguinity in the couple, mother and father will share some SNP regions, and therefore the panorama test could not give you back a result. If you use a counting method, there is no problem. In higher order multiples, you cannot use neither counting nor SNP-based methods. With twin pregnancies, you can use these tests, but the sensitivity is lower than in singletons, as you will see in one of my last slides. Also, if there is a vanishing twin, you will not become a result back if you use a SNP method, and the test will tell you, I cannot give you a result because there is a vanishing twin. If you use a counting method, vanishing twin could be a cause of false positive, as we will see also at the end of my presentation. And why do test failure matter in NIPT? First, because real no-call rates are usually higher than that recognized by laboratories, although I showed you a few minutes ago that in our case we have lower no-call rates with panorama than the published one. Second, because there are high published redo failure rates. If you tell the patient, you haven't got a result, but let's try again, it is quite likely that in the next test we also have a failure. And what is really important, that there is an increased incidence of aneuploidies in no-call cases. And in fact, the American College of Medical Genetics and Genomics recommends to offer diagnostic testing for no-call NIPS result due to low fetal fraction. But the same college says that if the maternal blood for NIPS was drawn at an appropriate gestational age, a repeat blood draw is not appropriate. So if you did the blood test at 13 or 14 weeks of gestation, it has usually no sense to obtain another sample. Also, the American College recommends to offer aneuploidy screening other than NIPS in cases of significant obesity. As I told you, there's an increased likelihood that you have a low fetal fraction, so go directly to another screening methods, either combined screening or go directly to an invasive procedure. And they also say that all laboratories should specify the reason for no call when reporting NIPS result, and this is important. And also all laboratories should include a clearly visible fetal fraction on NIPS report. And if you see, they use the concept NIPS, non-invasive prenatal screening, and not NIPT, that is non-invasive prenatal testing. It is a screening method, but combined screening is also non-invasive. Therefore, you may change the name of this kind of tests. And to illustrate how the no-calls impact on clinical practice, I brought you this this slide. That is a theoretical exercise in a population of 100,000 pregnant women. If you have a test failure rate of 10% for the same detection rate, you will have to do 10,000 additional invasive testings, and you will have only a 2% positive predictive value. Whereas if the test failure rate is 1 in 1,000, like the one of Verify, then you will only need to do 100 additional testing, and the positive predictive value will rise up to more than 67%. And you will not have procedure-related losses. If you have to do so many amniocentesis or CVS, you will lose several pregnancies. And what is the second main limitation? The second main limitation is that NIPT does not always give back true results. It has false positives and false negatives. This illustrates that all tests have detection rates above 98% when we look for trisomy 21, 18, and 13. And if we focus only on trisomy 21, all have detection rates above 99.99%. But again, the false positive in the lower part of the slide are much higher in tests that use shotgun sequencing. Here you have one false positive out of 500 tests, whereas if you use the Ariosa harmony test or the panorama test, the false positive rate is around 1 in 2,000. And why do you can have false positive results? One is if you have a vanishing twin and you haven't diagnosed it early in pregnancy. If there's a non-ongoing twin, this will be probably related to chromosomal abnormalities, and this will be detected by the NIPT. If you use a counting method, if you use the panorama test, they will tell you we cannot give you a result back because there's a vanishing twin that you have missed. Another possibility of a false positive result is that there is a placental confined mosaicism. If the fetus is normal but there is a mosaicism in the placenta, you will, the NIPT will detect this mosaicism and will tell you that the fetus is abnormal, although it is not. Therefore, also, if you have an absolutely normal ultrasound and the NIPS tells you that there is a chromosomal abnormality, please do not do a CVS, but do an amniocentesis. Wait a few weeks and do then the amniocentesis. And mosaicism could also be due to maternal mosaicism. As maternal age increases, the incidence of monosomy X in nucleated blood cells increases, and it is up to 2 to 4% in women between 40 and 50 years of age. So if you have pregnant women at over 40 with IVF procedures, with surrogations and all these problems, then you may have a false positive for Turner syndrome related to maternal age. But another source of false positive results are maternal malignancies, maternal cancer. And this is a report of the cases published so far. You can see that the chromosomes that are involved usually are trisomy 13, monosomy 18, or combined aneuploidies. So if you have an absolutely normal ultrasound, the NIPT tells you that there is a chromosomal abnormality, you do the invasive procedure and it is also normal, then think about this possibility. There are different cancer types that have been related with abnormal NIPT findings, especially non-Hodgkin lymphomas, but also gastrointestinal cancers. So this is something that you should think about. With regard to false negative results, almost all are due to low fetal fractions. If the fetal fraction is low, you have an abnormal ultrasound. Please don't rely on the NIPT if it is normal. In fact, if the nuchal translucency is quite above the 99th centiles, I would recommend you to perform an invasive procedure and an MRI to discard fetal problems. You can also have false negative results if the pregnancy is polyploid. If you have such an image of a trophoblastic that arises a suspicion of a trophoblastic disease, don't do an NIPS, especially if you use the counting method, because although there is an extra set of chromosomes, the ratio between the chromosome 21, 13, or 18 to chromosome 3 remains the same. Therefore, it does not work. You will miss a polyploidy if you do non-invasive prenatal testing. And again, mosaicism could be a cause of false negative result. If the placenta is normal and the fetus has the mosaicism, you will miss it with an NIPT, as you would miss it if you perform a CVS. Therefore, if you suspect a chromosomal abnormality because you have a malformed fetus or an increased nuchal translucency, don't do NIPT, neither chorionic villus sampling, better go directly to an amniocentesis a little later on. And this is the review of false positives that have been published so far. As you can see, most of them are false positive, 88%. Only 12% are false positives, and from the false negatives, sorry. And from the false positives, only 33% have a biological or technological explanation. In 2/3 of the cases, we don't have an explanation. And from the part where we have an explanation, almost half of them are due to maternal copy number variations, what I told you about the monosomy X. 1/3 are related to confined placental mosaicism. 15% are related to maternal malignancies, and 2% are related to a vanished twin. Finally, from those false negatives, only half of them have an explanation, and most of them are related to a fetal mosaicism without the placenta being affected. So just to reach almost the end of my presentation, just to review that the multiple parallel sequencing tests have detection rates for trisomy 21 of 99%, with false positive rates of 0.09%, whereas the detection rate drops for trisomy 18 and trisomy 13, and especially for monosomy X, as false positive rates also increase compared to chromosome 21. And this is a slide showing the positive predictive value of NIPT for different trisomies. Trisomy 21 almost 80%, trisomy 18 16%, so, and trisomy 13 only 30%. So if the NIPT tells you that there is a trisomy 13 and you have an absolutely normal ultrasound, then most likely the fetus will not have a trisomy 13. And what will be the future of NIPT? When I was a fellow, all efforts were directed to detect fetal cells in maternal circulation, not cell-free DNA, but fetal cells. And there seems to be a trend back to detect and isolate fetal cells and to do non-invasive prenatal testing, selecting these fetal cells in maternal circulation. I don't know whether it will come back in the next future or it will be a combination of both cell-based and cell-free DNA studies to do non-invasive prenatal testing, that if the technology achieves to do that properly, it will not yet be a screening test, but a diagnostic test. And these are my take-home messages. NIPT is here to stay, there is no doubt. It is the best aneuploidy screening method, far better than combined screening, but it is still a screening method. That may reflect chromosomal changes to the placenta, not to the fetus, or from the mother, as I told you. And don't forget to use NIPT according to the beliefs and wishes of the pregnant woman, and tell her that this will not discard all causes of cerebral palsy or of chromosomic syndromes and so on. Most patients think when you tell the NIPT is normal, so my baby does not have any disease, nothing. No, this is really not true. We are doing the NIPT to discard aneuploidies, and as we will listen later on this morning or this afternoon, it is also used to screen for monogenic diseases nowadays and microdeletions. But it does not discard all type of hereditary diseases. And this is all what I wanted to share with you. Thank you very much for your attention, and thank you, Aris, again, for your invitation. Thank you.